Hello, and welcome to today's episode of A Cancer Conversation with the Georgia Cancer Center. I am your host, Chris Curry. I am the Communications and Marketing Manager here at the Georgia Cancer Center. Today, I am joined by Dr. Martha Terris. Dr. Terris is the Chief of the Department of Urology here at Augusta University Health and the Medical College of Georgia. She is one of our urologic oncologists who sees bladder cancer patients. Today we're going to be talking about bladder cancer because May is Bladder Cancer Awareness Month. Dr. Terris, thank you for joining us today for today's conversation.
Thanks for inviting me.
Absolutely. I want to start today's conversation with a little bit more about you. Can you talk about what made you decide to pursue a career in urology and urologic oncology?
Well, back in the day when I started out in this field, there weren't very many women in it. And it was a field that was wide open, a lot of serious malignancies that was wide open for research and innovation, and that's what attracted me to it.
Okay. Talk about your career, how long you've been doing this, the changes that you've seen over the years when it comes to bladder cancer, surgical techniques, and things like that.
Sure. So bladder cancer, we initially diagnosed that with a cystoscopy. And even that has gotten much easier. The fiber optics and the level of HD video that we can do these scopes with very, very small scopes that are half the size of a pinky finger that we can look for these tumors, make the screening for them much more comfortable for patients. Then once a cancer is diagnosed, the first procedure we perform is a transurethral resection. The technology for that has also improved, not only the optics, but the delivery of energy. Instead of using standard electrocautery that's been around for many decades, we now have ways of delivering that energy to resect the tumor and cauterize the area that cuts down on the amount of bleeding, cuts down on the side effects, and cuts down on any damage to the tissue that makes the job harder for the pathologist to decide whether that's a tumor that's going to need additional treatment or if we've taken care of it with that procedure. Finally, if it's really bad and we have to do chemotherapy and bigger surgery, the chemotherapy options have improved dramatically. There's medications that employ your immune system more than just killing everything in the area. As well as the surgery, we've got robotic surgery. So we can do the surgery with much less invasive surgery that the patient recovers from more quickly and has less discomfort.
And let's talk about a really big honor that you actually have been awarded from the American Urological Association. Talk about this award and what it means for you to be recognized in your career being a partner in bladder and other types of urologic cancers with patients.
Thanks so much for bringing that up. Yes, I just found out I was awarded a Distinguished Service Award from the American Urologic Association for my research in cancer, specifically prostate cancer for that award, but even other services such as resident education and other things. So it is a big honor that I'm accepting later this month.
That's awesome. What does it mean to be able to kind of teach residents and share information and career advice with them as they are kind of going through their rotation?
Yeah, that I could go into a very deep emotional talk about
Well,
that
we have
because
some time.
because I mean, what is your legacy, right? I mean, surely your own children and their children's children, but then how many medical students do you encourage to go into treating cancer or into urology or urologic surgery? And then how many residents do you train to be very good surgeons and very good clinicians and very caring individuals for patients? And how many do they go on to train, and so on and so forth? So that really gets into what keeps me coming to work every day, right? That's the really not only taking care of wonderful patients and hoping to provide them with a good outcome, but providing for generations and generations of patients to come by training the doctors that will take care of them.
And let's talk about bladder cancer patients specifically. What is it like to be there side by side in their treatment process and then following up with them afterwards?
Yeah, it's tricky. So you go from it's a balance between this potentially life-threatening cancer. Now, a lot of bladder cancers are not life-threatening. They're just a little more than a polyp that we take out and then we keep a close eye on them to be sure it doesn't come back, to very life-threatening cancers that are very difficult for us to treat. So first of all, there's the dichotomy and just the seriousness of the conversations we have, of course. But then for those with the more serious disease, you get them over the life-threatening part, and then you get to address all the quality of life issues. If you're not urinating like a normal person, or your sexual function is impacted, or some of these other issues that come up from treatment, then that's a whole nother conversation that requires a really good relationship with the patient to address them.
What do you do to build those relationships with the patients?
I think as long as you show that you're comfortable talking about the topics, that you're knowledgeable about the topics, and that you're willing to talk to them about their topics, that they're not going to shy away from letting you know about what's bothering them.
Okay. So we talk a lot about, and you hear it a lot about in the news and in the media about breast cancer and prostate cancer, but you don't hear a lot about lung or bladder cancer. How common is bladder cancer?
Bladder cancer is really common. It's still one of the top killers of patients in Georgia and South Carolina. A lot of that is because we still have a lot of people that smoke in our area, but there's a lot of petroleum industry, a lot of people that work with pigments, whether it be paints or other things. So there's a lot of risk factors that we have here that make our patients at higher risk for developing bladder cancer.
And is there a screening opportunity for bladder cancer, or is it just something goes wrong and that's when you know?
Yeah, that's a great question. It can be a silent killer, you're right. Usually the first thing people see will maybe be a little blood in the urine or some burning and stinging when they pee. And unfortunately, that's exactly what it feels like to have a bladder infection. So many patients will go by an urgent care or go by, you just call up their primary care doctor and say, oh, I've got a bladder infection, get antibiotics, and end up putting off for months, maybe years, the diagnosis. And that's really the message for everybody, is if you have these symptoms of bladder discomfort, burning when you urinate, a little blood in the urine, that you go grab an antibiotic. Even if it goes away with that antibiotic, it could still be a bladder cancer. Please let us take a look at you and be sure it's not something more serious.
Okay, that is good information. All right, besides smoking and the sort of the environmental things that you talked about, are there any other warning signs or risk factors to be aware of when it comes to bladder cancer?
Some patients, due to neurologic issues or maybe where they live, may be more prone to other types of cancers. For example, patients that have a catheter all the time for some reason, regardless of where that catheter is going in their bladder, are at higher risk for squamous cell carcinoma of the bladder. Also, patients who live in Egypt, where schistosomiasis is a prevalent disease, very high risk for squamous cell carcinoma of the bladder. Here in the U.S., the urothelial carcinoma is more common, but there are certain risk factors, and certainly anybody's travel history or catheterization history is important when we're evaluating their bladder.
Okay. Talk about what sort of approach someone could expect if they came here to the Georgia Cancer Center to see you for bladder cancer. What would that experience be like for them?
So if they've already got a diagnosis, we would go over their pathology, any imaging tests they had, if there's anything missing as far as maybe they've had an x-ray but we want a PET scan or anything like that, of course would fill in the gaps for any of that. So many times the first visit is simply a fact-finding visit. If it's somebody that's never had a diagnosis, is just coming to see me because they saw some blood in their urine, there's 3 tests that we do. One is a urine cytology, send their urine sample to look for cancer cells in it. Another is a CAT scan to look for tumors in the kidneys, bladders, or kidney stone. That's another thing that could cause blood in the urine, but that same scan will show that to us. And the third is the cystoscopy, that procedure I described with our really fancy fiber optic scopes that we do just right here in clinic, and you drive yourself home after.
Oh, wow. Okay.
Yeah, no prep needed.
Nice. How long does that procedure take?
About 5 minutes.
Oh, wow. It's that fast.
Yeah.
That's awesome. Are there any clinical trials going on for bladder cancer that we can share information about?
Absolutely. There's new chemotherapy drugs coming out all the time. This is a really fascinating time to be involved in cancer care. The FDA is approving new drugs. We're trialing new drugs. Some of the most exciting things are that these bladder tumors that come back that aren't severe enough to need the bladder removed, for example, but we put chemotherapy in the bladder. There's newer drugs now that have come out for that, and even drugs that we can give IV in that situation without putting a catheter in, that have really expanded our ability to treat those recurrent tumors that we worry about getting worse.
Okay. And you talked about those 3 tests that you would do if someone came to you and did not have a diagnosis. Do you do all 3 of those tests at one time, or does it depend on each patient's situation?
It depends on their situation. I mean, usually they've come in, they haven't had anything done, so we'll talk to them, explain to them what we're going to do. We'll get the urine sample that day. That one's easy. And schedule them to have a CAT scan, then to come back and see us for the cystoscopy. By the time we see them, we will know the results of the urine cytology and the CAT scan, and we can share that information. And the cystoscopy is real time. We can tell them what it shows right then and there. So by the time they finish that second visit, they know the results.
Okay. Well, Dr. Terris, I appreciate you taking the time to join us today to have today's conversation about bladder cancer. I feel like this has been very informative for those who may be watching or listening. So thank you for your time today. And for those out there watching or listening, please follow, rate, review, subscribe to our podcast, A Cancer Conversation, with the Georgia Cancer Center at Augusta University. And we will see you next time.